Hello.
Hi there, it's Malka Stromer
And Janine Noble.
with Sound Sports Imaging. Welcome to today's webinar. If you have any questions, please don't hesitate to ask at the end. We will be answering questions. And if you have any later, you can reach us at info@soundsportsimaging.com or visit us at www.soundsportsimaging.com. Take it away, Janine.
Today's webinar is going to be one of my favorites. It's foot and ankle. And in honor of this, Malka got a pedicure. So things are good. And yeah, her feet are clean. Podiatry, foot and ankle, so much stuff can be done with foot and ankle. You've got your medial ankle tendons, the posterior tib, the flexor hallucis longus, and the digitorum longus, and the blood vessels in there, so Tom, Dick, and Very Nervous Harry. Then you've got your lateral tendons, which will be the peroneals, plus the ATFL and the CFL, the anterior talofibular ligament, and the calcaneofibular ligament. You've got your plantar fascia, the Achilles, spurring in both of them you can look at, stress fractures, neuromas, plantar plate disruption, you name it, you can see it in through there. The only thing you can't see is if you have internal derangement, and that's the same thing with any area of the body that you're looking at, that you need to get an x-ray or an MRI for that. But anything external, any of the tendons and ligaments is much better with ultrasound. So we are going to move off to the ultrasound screen. Perfect. All right, and I'm gonna move that down there so that you can see the foot. I'm just good. Now, people, we'll move you back just a tad. I've always done my scans this way with the patient's foot in my lap. I let them know there's no massage or pedicure involved with this, but I like to do this because I have more control over it than you do when they're seated on the table. The only one you may have trouble with is the Achilles. If you're only looking at Achilles, you can have the patient prone. Same with plantar fascia, but you can also work around it right through here. We have scrubs on because of the gel, but you'll probably want to put a towel on your lap if you're doing it this way. So, gonna start, I'm gonna have proximal to the left of the screen, distal to the right of the screen. Remember, skin surface is at the top of the screen. I'm gonna increase the gain just a little bit, and I'm going to decrease the depth. Gonna plop it right on the back where the Achilles is. And remember, the Achilles is a straight line, so it runs from calcaneus and up. Can we see this here? So I just have it in a straight line. What you're gonna see is the calcaneus. Oh, there's the cursor. So calcaneus right through here. This is the Achilles. Insertion, you got. And I two-hand this a lot of times because it's very, very slippery back through here. So calcaneus at the back, insertion. The little area right in through here is a kind of a drop-off. You'll probably see a little lack of signal there. That's anisotropy. That is not any kind of pathology. You're going to see that in almost every patient. As we run superior, you can see the width of the Achilles stays the same the entire way through. Beautiful Achilles. Okay, to right about there. If it changes width, if you have a tendinitis or a chronic tendinosis, what will happen is right around in this area, it'll just bulge. And it will be very, very obvious instead of the nice width here. And I think there's a normal measurement here of about 6 to 8 or 6.5 or something, but you'll see a bulge in through there. Now in this long view, I'm scanning lateral and medial to get through all the fibers. And then I'm going to rotate this 90 degrees. There we go. Now, the issue with Achilles is the fact that if you can see, the transducer width is greater than the width of the posterior foot. So you're going to have a little bit of drop off in signal along the side because we're not making contact. But this is the best way to see if you have spurring along the calcaneus. And this is a really nice looking foot. And onto the tendon right through there. And I'm just going to run this proximal. Again, no change in width, no change in intrasubstance texture. If there are tears within this, this is the area you'll really see them. The black holes in through there, calcifications in there. I'm just going to run it proximal, and this looks great. Which is good because she's not complaining of anything. Okay, excellent. The retrocalcaneal bursa, I'll go back to a long view, is right in through here. It's just in the at the proximal posterior calcaneal region. So it'll be in through here, and you'll see that get filled with fluid. Okay, down to the plantar fascia. On the fascia, the area that tends to get the most pathology is at the medial calcaneal tubercle. And there are 3 bands of the fascia that come up and attach at the calcaneus and run up to the base of the first met, or the base of the mets. But the medial band is the one where most of the problems take place. A couple of things here that you'll notice. Generally, you're going to need to increase your gain a little bit because the tissue on the bottom of the foot is quite thick. So I'm going to change the gain a little bit. And if you have frequency that you can change on your probe, you may want to drop that just a little bit if you're having a hard time seeing. The other is the focal zone. I'm going to move that up to right where the tissue is. So remember, bottom of the foot is the top of the screen. So skin surface is at the top of the screen. Oh, go ahead. So this is the bottom of the foot up through there. Through the tissues down to the calcaneus, right through there. And then the fascia inserts right through here and runs. I'm going to track this, and you'll see it starts to get more superficial as you go distal. And once you get up into this region, if you'll notice when you look at a number of patients, fibromas tend to happen in this area, and they'll be a lot of times within that band of tissue or just superficial to it. Okay, I'm going to go back to the calcaneus. This is where I would measure the fascia. I'm going to tap and tap. Hers is about, that's not totally even there. Let's see if I can move it over. Whoa. Okay. We'll pretend I know what I'm doing. But it's around 3.9 millimeters. A normal measurement is under 4.0 millimeters. Above that, I've seen them as high as 12, which was just ridiculous. It's one of those, oh my gosh moments. But you're also going to look for tearing in the fascia, any kind of disruption in these even fibers through here. But this looks perfectly normal. Now I'll go to a short axis view of this, and you should see about the same thing. We have the calcaneus, the white line, the hyperechoic line. As I go distal, now we're on the fascia in a short axis view. Now, if you'll notice, I'm going to push on this medial side of her foot, and you can see the fat pad moving across the top of the fascia, while the fascia stays down. And anytime finding it, that's a good way to locate it. Okay, medially, running out of gel. And it's like squirting all over the place. Okay, again, proximal is going to be to the left of the screen. And I'm going to start just directly on top of the malleolus. There you go. So malleolus, very top of the screen. No matter who it is, it's going to be at the top of the screen. And I'm going to slowly go posterior. Bingo. Right on top of that. Now, the thing that people tend to do is go a little too quickly here, and they end up on the flexor digitorum. You need to start slow, and first tendon you see is going to be the posterior tib. And the fibers are right in through here. It looks like a nice ropey appearance to it. And the other way you can tell where you are is our favorite with musculoskeletal ultrasound, we can use movement. So I'm going to invert her foot, and you can see the fibers moving. Track this down to the navicular right there. There's the navicular, and you can see the fibers coming in. Then I'll go back to, once we've got the posterior tib, go a little more posterior, further behind, and flexor digitorum. And I'm gonna have her wiggle her toes. There's the flexor digitorum. Then the next thing will be the blood vessel. That would be the tibial artery, and then the flexor hallucis longus. If they move, they're intact. Now, the other you can do is a short axis through here. And this is how some people like to find this to begin with. I prefer long axis, but you can always go short. And this is a picture that you'll see in books. So you have your malleolus, posterior tib. Again, we'll just invert and see it moving. Then the flexor digitorum, and then the flexor hallucis down below here. This is the tarsal tunnel region. So you have blood vessels in through here, and your tibial nerve is right down in here. Injections are done in through here. The ligament runs across the top of that. They'll remove that sometimes in tarsal tunnel syndrome. A lot of injections are placed into this area. But again, use movement to your advantage as you're doing this. Now, over to the lateral ankle. And one thing to know is MRI, this is excellent for the perineal tendons. MRIs tend to miss a little bit of this. But no, straight out. Nobody wants to relax when we do this. All right, so the MRI will frequently miss perineal tendons because as it comes along underneath the malleolus, the image doesn't get along in through there. So with this, you can't miss them. So again, on top of the malleolus, slightly posterior. Beautiful picture. Okay, so I'm gonna freeze this. Okay. You have your peroneus longus here, the peroneus brevis down below. This is malleolus, and we'll track those down. Look at that. So gonna do inversion, eversion with this, so you can see the tendons. What you'll see in through here is tendinitis a lot of times, or a tenosynovitis, where the sheath gets black, and you'll just see a black line that runs all the way down through here. So I'm gonna track this distally, and this gets cool because just like we learned in school, the longus dives down and goes underneath the foot, and then we'll pick up the brevis, which goes over to the base of the fifth met, right through here. So you have tendon coming in through here. Now, right below that, we have cuboid. So you can see stress fractures along the cuboid. You can look for stress fractures along the base of the fifth met. Then to a short axis, there we go. All right, we have our, I can get both of them in here. Brevis and longus, and you can see the movement. And I'm going to put her into a strong inversion here, and the tendon doesn't move. And sometimes you'll see these where either the brevis will get split or the tendon will come up and over, but this is all looking pretty good. For the anterior talofibular ligament, exactly what it says, from the talus or the fibula to the talus. And I'm just going to maneuver the probe around a little until we have a good picture of the ligament in through here. It's broad and thick. And again, movement in through here, not going anywhere. Okay. Then up to anterior. Good. The anterior tibial tendon runs right along through here. To the bottom of the foot, I'm going to show you where you would look for neuromas. I tend to like to look for them in a long axis view. There are people who look at them in a short axis view. Again, I am on the third. Bottom of the foot is the top of the, is the skin surface. So this is the bottom of the foot. This is the third met head and the phalanx. And you can tell where you are by movement. So I'm going to go back and forth. So now I'm on the fourth. And in between, in that space, is the interdigital nerve. And what you'll see is a big ball of fluid around that nerve. It's very, very easy to pick up. Okay, in a short axis, you'll look for both met heads here. And again, double check to make sure you know where you are. And then the nerve is right in between these. And you can do a little movement. And what you'll see is for the Mulder's click, you'll see that neuroma pop up and out of there. And that is an ankle exam. Again, you can see so many things in the foot and ankle. It's very, very easy, from plantar fascia to Achilles to all the ankle tendons. And the movement that's within these is what really helps bring out what's going on to determine tears versus tendonitis versus tenosynovitis. So, well,
thank you all for joining us today. As always, Sound Sports Imaging provides solutions to all your ultrasound needs.
See you next week.
Take care.
Bye.